All right, let's talk PFTs. We're going to do a super rapid review designed to help you absolutely crush these questions on your exams. My goal here is to give you a simple, repeatable system so you can look at any PFT question and just nail it with confidence, every single time.
So you see this on an exam, right? You get this squiggly loop, a couple of numbers, and you know the clock is ticking. It can feel pretty intimidating, but what if I told you there's a foolproof way to solve this in just a few seconds?
I promise you, you absolutely will. I'm about to walk you through a really simple, systematic approach to get these questions right. It's an algorithm, and it all starts with just one crucial number.
Okay, let's dive right in. Step 1, the very first number you should look for on any PFT report is the FEV1 to FVC ratio. Seriously, this is your starting point. It's the anchor for the entire diagnosis.
This ratio is your first major clue, so FEV1 is the volume you can force out in 1 second, and FVC is the total volume you can force out, right? Well, the relationship between them, that instantly puts you on one of two main paths. Either it's an obstructive disease or it's a restrictive disease. It's a fork in the road.
And check this out. Look how cleanly this one number divides everything. For obstructive diseases, the problem is you can't get the air out. So your FEV1 is way down, and that drops the ratio below 70%. But for restrictive diseases, the problem is you can't get enough air in, so both numbers go down, and the ratio actually stays normal or even gets high, usually above 80%. Okay, so that's step 1. Now, for step 2, let's move to the visual part. Once you know the category from that ratio, the shape of the flow volume loop is going to confirm it for you and give you even more clues.
And you really don't need to be an artist here. You just need to recognize two really simple shapes. The obstructive pattern has this classic concave, scooped-out look. That's because the small airways are collapsing when the person tries to breathe out. The restrictive pattern, well, it just looks like a tiny, shrunken version of a normal loop. People love to call it a tall, narrow witch's hat.
And this slide brilliantly shows you the why behind the total lung capacity, or TLC. See, with obstructive disease, you get air trapping, right? So that increases the total lung capacity, and it shifts the whole loop to the left toward bigger volumes. But with restrictive disease, the lungs are smaller, they're stiffer, so the TLC is decreased, and that shifts the loop to the right toward lower volumes. Left for large, right for restricted. Okay, so you've nailed the pattern. It's either obstructive or restrictive. The next step, especially for your exam, is to know the most common causes for each of those patterns. You need to know your list of suspects.
For obstructive diseases, this is probably one of the highest yield mnemonics you can learn. Just remember, CBABE, cystic fibrosis, chronic bronchitis, asthma, bronchiectasis, and emphysema. If you see that scooped-out loop, one of these 5 is almost always going to be your answer.
Now, for restrictive diseases, it's really helpful to think about where the problem is. Is it intrinsic, meaning it's inside the lung tissue itself, like with fibrosis or sarcoidosis? Or is it extrinsic, something from the outside is compressing the lungs, like obesity or really curved spine from kyphoscoliosis?
So we're on to step 3. We need a tiebreaker. This is how we're going to differentiate between diseases that can look pretty similar, like telling emphysema apart from chronic bronchitis. And this is where your secret weapon comes in, the DLCO.
Okay, so DLCO measures how well gas gets from your lungs into your blood. Think of it like this. In emphysema, the lung walls are literally destroyed, so gas can't cross. That means your DLCO is low. But in chronic bronchitis or asthma, the problem is in the airways. The pipes are clogged, but the walls are fine, so the DLCO is normal. On the restrictive side, if the lung tissue is thick and scarred from fibrosis, gas can't get through, so low DLCO. But if it's just obesity squishing the lungs, the tissue itself is healthy, so the DLCO will be normal. See? It's the perfect tiebreaker.
Okay, enough theory. Let's put our simple 3-step algorithm to the test. We're going to run through a couple of classic, super high-yield exam questions. All right, take a look at this first case. You've got a smoker, you've got that classic loop shape, you've got the ratio, and you've got the DLCO. Let's walk through the steps together and just lock in this diagnosis.
Okay, here we go. Step 1. The ratio is 55%. That's less than 70%, so bam, it's obstructive. Step 2. The loop is scooped out, which just confirms our obstructive pattern. Step 3. The DLCO is low. And that is our tiebreaker.
So a low DLCO and an obstructive pattern. What does that point to?
It points directly to the destruction of the alveolar walls. And that is the textbook definition of emphysema. See how easy that was?
Perfect. Let's do one more. This is another really common exam scenario. Different patient, different numbers, but we are going to apply the exact same process. Don't let the new details throw you off one bit. All right, let's run the algorithm again. Step 1, the ratio is 85%. That's high, so we're thinking restrictive. Step 2, the loop shape is that tall and narrow witch's hat, confirms restrictive. Step 3, the DLCO is low. That's our final clue. So in this case, a restrictive pattern plus a low DLCO tells us the problem is inside the lung tissue itself. It's making it hard for gas to diffuse. And that is the absolute hallmark of an interstitial lung disease, like pulmonary fibrosis.
Now, to pull all of this together and make it incredibly easy for you to review, here it is. This is the one slide you need to screenshot or burn into your memory before your exam.
This table is our entire 3-step algorithm in one place. It lays out the most common diseases you'll see on the test and shows you exactly how to tell them apart based on the ratio, the loop shape, and that crucial tiebreaker, the DLCO. This right here is your key to getting these points on exam day.
So there you have it, the systematic approach. Ratio, shape, DLCO. With this algorithm, you can turn what looks like a really confusing PFT question into easy points. This isn't just about memorizing facts. It's about having a powerful system to think like a clinician when you're under pressure. You've got this.